NS or NRS, it is difficult to draw conclusions. This study by Richard Nord from St. Hopkins Hospital, in a randomized controlled trial, he showed that patients operated for a back condition and who were faced with the dilemma of having another operation or being prescribed neurostimulation, results were greater in the group that was referred to neurostimulation than in the group who was reoperated. This is another group, spinal cord stimulation with neuropathic pain. If spinal intervention is compared to the best possible medical treatment, well, we participated in this study. Actually, we noticed that neurostimulated patients had a better pain control than the other group versus 9% in patients who received standard medical treatment, the best medical treatment on offer. After some time, the groups were crossed, but in the end, results were better in the group stimulated via the spinal cord. With regard to motor cortex stimulation at the beginning of this year, and a Mexican group treated a number of patients for pain, and at a given time the stimulator was stopped. Patients don't feel anything in this case, and so this could be a blind study. It was noticed that when the stimulator was switched off, the pain was back to the level prior to surgery. The problem with this study is the fact that it only included 8 patients, but anyway, it is the first blind trial. So there are evidences in pain, and with the other cases, psychosurgery, epilepsy, existing studies or trials are very short series, and therefore no scientific evidences can be drawn. Another issue, complications. 35% of patients with spinal cord stimulation present some type of complication related to the hardware. Or see this type of situation here where the cable is twisted or the electrodes may break, the generator may have fault. These are quite rather bulky devices, and so in thin patients they can get ulcers over the area of the generator on the skin. These situations need to be overcome by jointly working together, doctors and engineers. Some of these complications are associated to infection, and so we must come up with a successful system to avoid this type of complications. As to the cost-effective situation, well, these implantation techniques are not particularly cheap. There are very few studies doing a cost-benefit analysis, and one of them is by Dr. Kuhlman. They compared the group neurostimulated with the group treated medically. The cost of the spinal cord stimulation was lower and therefore the cost of the prosthesis of the implant was actually paid off over a 2-year period, while the payoff of the investment in the other case was longer. The payoff period was almost 7 years, and they went back to work earlier too. In the Parkinson's disease, our colleagues from the Clinical Hospital of Barcelona compared a number of patients, comparing the cost of the implantation versus continuing the medical treatment over a year. They noticed that by one increase in the QALY rate meant a cost of 239 euros per point on the scale, and the economic cost of the stimulated group was 34,000 euros per year. So in the medical group, the cost, so in this case, spinal cord treatment, neurostimulation was higher. However, in the other group, none of the patients improved clinically. And so they maintained that situation by increasing the drug treatment by 1.7%. Sorry, by 3.6. So if this study were made longer for more years, that increase in the non-operated group would actually make up for the cost of the implantation of the device. Another problem we face is the follow-up of the patients. The programming takes hours. The company should work harder. The manufacturers of these devices should come up with devices easier to program, and patients, when the parameters are changed, the patients have to go to hospital, or when the battery runs out, it needs to be changed. So longer or lasting batteries should be found. In recent years, rechargeable systems have been released for spinal cord stimulation, and will shortly released for deep brain stimulation to overcome the replacement of the battery. Further research is needed to improve the software, to open up avenues for remote control or remote monitoring of these systems. It would be great if we could find more compact systems. Those working in nanotechnology here could really help us in finding smaller system using less power too. As I said, this is also used in epilepsy. It could be interesting to have smart systems in which not only a signal could be sent to the nervous system, but one that could collect information on the structures, on the nervous structures, and a system that could be self-programmable or self-modulated to better match the needs of the patients at a given moment in time. In epilepsy situations, it could be great if it could register the epileptic seizure or crisis the same way pacemakers control atrial fibrillation. Conclusions. Neurostimulation is an important technique in the therapeutic environment and in the treatment of abnormal situations and pain. A better understanding of pathological mechanisms will help us improve patient selection, target groups, and to broaden the range of indications or neurological diseases to treat. Technological improvement, and in this respect the engineers should get involved, could lower the complications related to these devices, and so we could prolong the battery life and improve the welfare of patients. Thank you very much for your attention.